Good evening, everyone. It's nice to be back with everyone talking about CMR. Today, as Julie mentioned, is going to be some interesting cases. I'm going to try to share my screen. Share. Can everyone see my screen?
Yes.
Yes? Okay, great. Okay, so first case is there we go. Okay, so first, sorry about that. So first case is a 61-year-old gentleman. He's got a history of paroxysmal atrial fibrillation and hypertension. He's got some fatigue, but he denied any overt chest discomfort, shortness of breath. The patient is a highly functional, busy professional, and he's in his electrophysiologist's office, or EP, and the electrophysiologist has had a relationship with him over the last 5 years, wanted to initiate propafenone for better management of his atrial fibrillation. So he did what many cardiologists would do, is he wanted to make sure that this patient did not have ischemic heart disease or structural heart disease. So he ordered an echocardiogram and a vasodilator SPECT, nuclear perfusion stress imaging study. The results were favorable. The nuclear stress test was normal perfusion, normal gated SPECT ejection fraction, and likewise the echocardiogram was normal as well. So at the office visit with the patient, after the normal nuclear stress test, after the normal echocardiogram, the patient informed the electrophysiologist for the first time that he was hospitalized for chest discomfort while traveling in Scotland about 7 years ago. And as you can see, I have here in bold, he said, "I was told I had a heart attack, but I guess they were wrong." So that created some dilemmas for my partner, the electrophysiologist, 2 dilemmas specifically. The first dilemma is that propafenone is an antiarrhythmic that is contraindicated in patients with prior myocardial infarction. It's proarrhythmic, worsening outcome with this therapy in that context. And the nuclear stress imaging study in the echocardiogram showed no evidence of myocardial infarction. Second dilemma, and one might argue the more important dilemma, is that the patient was a very prominent malpractice attorney. So the electrophysiologist was quite distressed, went down to the MRI department and asked about late gadolinium enhancement imaging. This is a case, by the way, that's more than a decade old, so it wasn't as well known as it is now, and asked if we could see an infarction that took place 7 years ago. And we said, sure. So we got the patient in for their CMR study. And here are 2 representative images, short axis images, a mid short axis image on the left and an apical short axis image on the right. I know everyone on the call knows that black myocardium on these images is normal. White myocardium or high signal indicates scar. So if we look at the image on the right, that's a apical short axis, and there's no evidence of infarction. But I'm sure it's already caught your attention that the mid short axis image on the left, there's a small subnocardial infarction in that mid lateral wall. So that would be a circumflex, obtuse marginal branch distribution. And that's it. I'm not showing you all the delay enhancement imaging, but that's the extent of the infarction. It's there, it's small. And as you can see, I have on the bottom, there's data going back approximately 20 years that SPECT nuclear perfusion imaging misses up to 50% of subendocardial infarctions, generally infarctions that are 10% or less of the ventricular mass compared to LGE imaging. And here's some examples from that study. So if you look at the top row, there are several patients with lateral wall subendocardial infarctions and apical and perceptual infarction and kind of an apical inferior apex infarction that, although well visualized on LGE imaging, were not seen on the corresponding nuclear perfusion images on the top row. The patient on the bottom actually has a fairly extensive infarction from a circumferential standpoint involving the mid and apical LAD distribution myocardium. But because the transmural extent of scarring is rather limited, the nuclear perfusion imaging was normal. And again, in this study, approximately 50% of these subendocardial infarctions were not identified on SPECT. So now I have the city images. So it's the exact same short axis slices, the mid short axis on the left, the apical short axis on the right, of the LGE imaging I just showed you a few minutes ago. And if we look at the lateral wall on that mid short axis slice, there is no impairment of lateral wall thickening. So the systolic function in the distribution of that infarction is normal. However, I'm sure you have appreciated that there's another abnormality on these images, which is the mid-anterior septum. If you look at the apical short axis in each slice, there's really severe hypokinesis or akinesis of the apical anterior wall and apical anterior septum. Now, one might say, well, is that from a myocardial infarction? And the answer is no. We just saw the LGE imaging of those two same slices, and there is no scar in this region. This is not a stress perfusion study, so it's not stress-induced ischemia. This is the patient just in the magnet with the coil in their chest. So the implication here is that there's severe resting ischemia without infarction, implying that there's probably very high-grade proximal LAD stenosis. So with this information from the CMR, obviously very much counter to what was seen on his traditional non-invasive cardiac imaging, the nuclear perfusion and the echocardiogram, my electrophysiology partner went back to the patient, had a very difficult conversation, kind of backtracking the earlier normal findings, and said that yes, you had a small heart attack in Scotland 7 years ago, but more importantly, I'm concerned about some severe blockages in your most important arteries. So after that difficult discussion, the patient did agree to undergo heart catheterization, diagnostic angiography, and sure enough, there was a high-grade 95% proximal LAD. His coronary circulation was left dominant, and there was just lots of severe disease in his OM, circumflex, posterolateral, and LPDA. With that, he within the week he underwent coronary bypass surgery with a Lima graft to the LAD, radiograph to from the Lima to sequential circ branches, and had an excellent outcome. Did very well. I'm going to also present a second case, if that's okay. The second case is a 32-year-old woman who was admitted to Carolinas Medical Center, where I practice here in Charlotte, with an embolic stroke after presenting with sudden onset of left-sided weakness. Her past medical history is hypertrophic cardiomyopathy that was diagnosed at the age of 12 after auscultating a murmur. So she's had known HCM for about 20 years. Asymptomatic previously. She also has a sister with hypertrophic cardiomyopathy that has an ICD. Fortunately, she received prompt thrombolytic therapy with TPA and made a near full neurologic recovery from her stroke. Her echocardiogram during this admission demonstrated severe concentric LVH, an ejection fraction of 50%, and they noted that there was hypokinesis to akinesis of the apical left ventricle. They also saw systolic anterior motion of the anterior leaflet of the mitral valve with a resting outflow tract gradient of 25. Her exam was otherwise, her physical exam was benign other than the auscultation of a mid-systolic murmur along the left sternal border. Telemetry monitoring demonstrated recurrent long runs of non-sustained ventricular tachycardia, no atrial fibrillation. So what next? How should we proceed in evaluating her subsequently? Is there any way that we can tie in what was seen on the echocardiogram, her history of HCM, and her acute stroke presentation? Here's her electrocardiogram, which demonstrates sinus rhythm. There's some minor non-specific repolarization findings. Some generous QRS voltage in the precordial leads, but not overt left ventricular hypertrophy, interestingly. So here's, she underwent cardiac MRI imaging, of course, and so here's a couple of cine images. There's a mid-short axis on the left and a four-chamber on the right. Now, if we look closely, there's several findings to point out. So one, of course, is the marked hypertrophy of the interventricular septum. You can see that on the four-chamber view on the base, extending into the apical ventricular level. And on the short axis view on the left, we can see marked hypertrophy of that mid-septum. And if you look closely, even the apical RV looks like it might be more hypertrophy than we would anticipate in a non-HCM patient. But beyond that, there's also one other finding, which is if you look at the mid-short axis slice, and if you call your attention to the anterior wall, not only is it not hypertrophy, maybe it's slightly thin, but it's not really moving, right? It's severely hypokinetic to akinetic. So here's two more cine images. The image on the left is a three-chamber, again showing that marked septal hypertrophy, basal and mid. We can see a elongated anterior leaflet of the mitral valve with systolic anterior motion, and that anterior leaflet moving over towards that hypertrophied septum in the outflow tract. We also can see that the apical septum, there's this kind of abrupt transition from very hypertrophy to somewhat thin and akinetic. The apex is akinetic too. The image on the right is right ventricular view, again demonstrating kind of what we saw a little bit on that four-chamber view, that there is some evidence of significant right ventricular hypertrophy. So the LGE images kind of tell the story here. So the four-chamber view on the left, there's extensive scarring within that hypertrophied septum. And then if we train our eye to look at the apical ventricle, you can see kind of transmural, essentially scarring of the apical septum, a little bit of the apical lateral wall. The short axis view on the right shows kind of the typical dense, kind of bizarre, oftentimes mid-myocardial, subepicardial scarring that you can see in hypertrophic cardiomyopathy. But these two views are very important. So there's a two-chamber LG image on the left and a three-chamber on the right. So let's start with the image on the right. So it's a three-chamber. Again, kind of that very prominent mid-myocardial scarring here in the hypertrophied regions that's consistent with hyperenhancement associated with HCM. But look at here. We have dense transmural infarct of the apical septum, LV apex, extending into the lateral wall. Here on the two-chamber, we can see that roughly half of the anterior wall, kind of here's at the midpoint, is transmurally scarred out to the apex. So this is an example of a patient with two scar patterns, a CAD scar pattern. So there's clear evidence of a prior LAD distribution transmural infarction, and a non-CAD scar pattern, the prominent mid-myocardial kind of patchy scarring that we see in the hypertrophied regions, the hypertrophied septum. So again, this would represent a good example of someone with both CAD and non-CAD hyperenhancement. So how do we put this together? It's certainly possible that this patient had an embolic subclinical infarction at some point in the past. He had no prior history of a myocardial infarction. May have developed a small apical thrombus in this akinetic, transmurally scarred LAD myocardia. And unfortunately, it may have embolized, resulting in her embolic stroke. The rest of her evaluation, just to kind of wrap this up, she had a coronary CTA demonstrating what you would anticipate, which is normal coronaries. She ended up with a primary ICD based on her extensive non-sustained ventricular tachycardia, very extensive scarring on CMR in the context of HCM. She was initiated on apixaban, 5 milligrams BID, and metoprolol succinate, 25 milligrams. And she was enrolled in the Sanger Heart and Vascular Institute hypertrophic cardiomyopathy clinic. So that's the end of my second case, and thank you for your attention.
Gracias, doctor Elliot, por los dos interesantes casos, donde en realidad la resonancia magnética cumplió un rol decisivo en el manejo de los pacientes. Vamos a pasar a los siguientes casos y al final hacemos las preguntas. ¿Le parece?
Oh, absolutely.
Ok. Ahora continuaremos con el doctor Daniel Balihan, que también es del Sanger y nos presentará otros casos clínicos. Oops.
All right, can you guys see my screen okay?
Yes.
Okay. All right, so for my presentation, I'll be doing case presentation on atrial switch operation for detransposition of the great arteries. I think everyone is probably pretty familiar with this, but I do want to briefly go through the anatomy. So you start with great arteries that are connected to the wrong ventricles. You have the aorta that is connected to the pulmonary ventricle, or the right ventricle, and you have the pulmonary arteries connected to the left ventricle. So you have deoxygenated blood coming in from the SVC and the IVC and going to the aorta, and oxygenated blood coming in from the pulmonary veins and going back to the pulmonary arteries. The atrial switch operation physiologically corrects this by redirecting venous return so that instead goes to the pulmonic ventricle, and pulmonary venous return is diverted to the systemic right ventricle. Prior to the atrial switch operation, what was done initially was an atrial septectomy, and then kind of, step by step, different techniques were developed that eventually led to these two atrial switch procedures, which became known as the Senning and the mustard procedures. Both of these techniques were developed in the 50s and 60s, and then they were really kind of popularized and became the treatment of choice in the 60s and 70s, and then largely abandoned in the late 80s as the arterial switch operation became more popular. It can be quite difficult to differentiate between the two on imaging, but there are some very important differences between the two. The Senning technique uses atrial and right atrial and septal tissue to create an intra-atrial baffle. It was originally thought to be a relatively difficult technique to perform, so initially the mustard procedure was actually a more popular option. The mustard procedure, we use pericardium or synthetic material to create a baffle, and it's this use of synthetic material that led to a higher complication rate, particularly baffle obstruction, and then eventually the Senning procedure became more popular because it had a lower complication rate, and then surgeons eventually became more comfortable doing the technique of that surgery. So long-term complications of these patients, there certainly are some other long-term complications, but here I'm specifically talking about complications as they relate to imaging. One of the big complications is arrhythmias, in particular 6 sinus syndrome, where the sinus node is damaged and the heart beats too slowly, but they can also get tachyarrhythmias. So up to a quarter of these patients at some point will end up requiring a pacemaker or ICD. Now, this is obviously not something we're directly evaluating on imaging, but it does impact whether we can image these patients with MRI or whether we need to go to CT because their device is not MRI compatible. Baffle obstruction, very common with these patients. Usually systemic venous baffle is more common than the pulmonary venous baffle to get an obstruction. When you have a baffle obstruction, SVC, you can get symptoms of SVC obstructive syndrome or SVC syndrome. When it's the IVC, you get a similar IVC obstructive syndrome. And when there's obstruction of the pulmonary venous baffle, you can get findings of pulmonary venous hypertension and symptoms mimicking heart failure if the obstruction is bad enough. They also get baffle leaks, and the prevalence of these leaks really just kind of depends on what modality is being used to look for them, and really what article you're looking at the time. There's probably somewhere in the range of 15 to 20% prevalence of baffle leaks at some point for these patients. Shunting from these leaks can occur in either direction and lead to things like volume overload, desaturation, and paradoxical embolus. Systemic RV dysfunction, this is a big one. This is definitely a problem for these patients, especially later in life, as the RV eventually has difficulty overcoming systemic pressure and systolic function decreases and the chamber becomes dilated. So this is a very important determinant of late morbidity and mortality for these patients. All right, so this is the first case. So this is a 41-year-old with transposition of the great arteries. He had a Muster procedure as an infant. So remember, the Muster procedure is the one that's more likely to have complications, more likely to have baffle obstruction, and that's really exactly what we see here. You start with the cine on the left. This is the SVC coming in here. This is the IVC, so this is the baffle coming into the left atrium. What we see is a severe stenosis at the superior limb of the systemic venous baffle. Then I'll show, pause this, and I'll show an MRA. Actually, I'm sorry, this is a dynamic first pass imaging. Just let that play. You can see the same thing, the severe narrowing at the central portion of that systemic venous baffle. So not a complete obstruction, but you can look at the SVC here, and it does look like contrast. It's just kind of hanging out in that SVC a bit longer than it should. So this patient didn't really have any signs of SVC syndrome and was relatively asymptomatic other than some mild fatigue. But he was about to undergo a pacemaker placement, and it was thought that the venous lead would exacerbate the stenosis, so he underwent balloon dilation and stent placement. So here on the cine images, kind of the same plan as we saw on that last slide. A lot of artifact from that stent, and that's one of the limitations of MRI, but you can see that stent is placed right where that obstruction was on the initial imaging. And then when we go to an oblique reformatted MRA, you essentially see, again, that stent is right where that stenosis was. You can definitely see that the narrowing and the lumen through that area is much more open than it was on the initial exam. All right, so same patient here. We're looking at pre and post-procedure MR images, 4-chamber oblique images. The one on the left is pre, the one on the right is post. You can see all the artifact here coming in from the stent. The RV volume was about the same on both images, so the RV was not dilated, just a few slight hypertrophy. But the RV function did significantly increase between the pre and the post imaging. On the initial MR, the ejection fraction was around 38%. And then on the post stent placement and post pacemaker placement, the RV function increased to 50%. So a definite functional improvement after stent placement and pacemaker implantation. All right, so this is another patient, another Muster procedure. This is a 59-year-old. And here we're looking at the pulmonary venous baffle. Systemic venous baffle is right here, kind of coming in at the crux there at the level of the atrium. This is the pulmonary venous baffle coming in, connecting to the right atrium. And here we see this discrete narrowing of the pulmonary venous baffle right as it's coming into the right atrium. And over on the right, again, this is a kind of reformatted MRA. And I'll just kind of scroll through that, and you see essentially the same thing, this very discrete narrowing of the pulmonary venous baffle right as it's coming into the right atrium. And so while this kind of looks like it might be a potentially functionally significant stenosis, the patient actually didn't have any symptoms of obstruction, and there wasn't much of a gradient here, so no intervention was performed. This is our third patient here. This is a 30-year-old with D, transposition of the great arteries. Again, this one had sending procedure instead of muscle procedure early in life. And I know this is a CT and we're supposed to be talking about MRI, and I'll show in a couple slides why I'm showing this one as a CT. So here on this first image here on the left, we're looking at the systemic venous baffle, so SVC coming in here. This is the baffle. This is the IVC coming in here. This is the inferior limb of the baffle. So that looks fine. So that's unobstructed, coming in normally to the left atrium. And then I'll show this sweep here, this 4-chamber oblique sweep, and we're looking at the SVC coming in here. As you come down, you get down to the intra-atrial level of the baffle. This is the pulmonary venous baffle coming into the right atrium. Again, that systemic venous baffle coming into the left atrium. See this large defect in the baffle, essentially a baffle dehiscence. So you have a large communication between the pulmonary and the systemic venous baffles. And I'll show the same thing on this kind of oblique cine CT image. SVC coming in, systemic venous baffle. This posterior is the pulmonary venous baffle. And you see a large communication. So a large baffle dehiscence here. So after this, patient went to cath, and he was found to have a QP/QS of 2:1, but this defect was too large to close percutaneously with a covered stent. So we ended up getting this defect surgically repaired. Same images as we had on that last slide. So we're looking at the systemic venous baffle. Sometimes after repair, you can get a recurrent obstruction of the systemic venous baffle, and this looks fine, it's wide open. Again, that oblique 4-chamber view again. So again, coming down, looking at the SVC, systemic venous baffle here, pulmonary venous baffle here, unobstructed, no residual recurrent leak here. And I'll show that same kind of oblique sagittal image, looking at the systemic venous baffle here, pulmonary venous baffle here. So no residual recurrent leak. So one just kind of visually looking at these 4-chamber images pre and post, you can definitely see initially that left ventricle was dilated, had mildly depressed function, that significantly improved after the repair. But I'm showing this, partly because it's a good example of a baffle leak, but also to talk about CT versus MRI. Ideally we would image all these patients with MRI, but this patient had a history of atrial flutter and severe sick sinus syndrome. So you had a pacemaker, which was not MRI compatible. And as I mentioned before, arrhythmia requiring pacemaker or ICD is not uncommon. So a good number of these patients will have to be imaged with CT over MRI. This patient was requested that in addition to showing the defect, that we also quantify ventricular volumes and function. So both of these patients were done as a functional CT. Functional CTs are high radiation dose because we're requiring images throughout the cardiac cycle. This initial exam, as you can see here, had a DLP of 809 milligram per centimeter, giving an estimated effective dose of 11.3 millisieverts. Second exam, post-procedure, had a DLP of 1,054, giving an effective dose of 14.8 millisievert. So just for comparison, in a patient of this size, just a routine contrast chest CT, the estimated effective dose would probably be somewhere around 3 millisieverts on the scanner this patient was done on. So between these two studies, the patient got an equivalent of 8 or 9 routine chest CTs. So these are really high dose examinations. In this case, kind of really illustrates that we should try to image these patients with MRI whenever possible, especially when we're doing repeat examinations. And when MRI isn't possible, we need to try to image CT and do everything we can to limit that radiation dose. And just kind of looking back and retrospectively looking at how our technique on these two CTs, I'd say we really probably should have been more aggressive on our dose reduction techniques, because these 11.3 on the first exam and 14.8 millisieverts on the second exam, it's just they're really high dose examinations. They're getting to the point where we have to worry about long-term radiation risk. So again, we can do CT when we need to. MRI is definitely the preferable modality whenever we can get away with it. That was all I had for this patient.